I don't know if you heard the videographer, he said, "Don't be afraid." I can tell you from firsthand experience that that was a good landing. Tecate International Airport in Tegucigalpa, Honduras is considered by many to be one of the most dangerous airports in the world. What makes it so dangerous? Well, you start with the mountainous terrain that surrounds the area, and as pilots then, and as you saw on the video, as pilots approach the runway that is sloped and elevated, it's only over a little over a mile long, that they come down and make a steep descent down this twisted ravine, and there are only a limited number of pilots in the world that are certified to fly into this airport. It requires unusual maneuvering. There is no autopilot. There is no flight director. These are pilots that are matching their wit and skill against the plane and the landing strip, and you don't want to come in at night because there aren't any landing lights. Now, keep in mind that there's only 500 feet that they have to land, or you have to do a flyby. And the danger is not only to the passengers on the plane, but as you saw in the video, there are homes that are right near the airport. There are people standing under the approachway, and at the far end of the runway, it falls over into the city below. Hello, I'm Rodney Richmond, and I'm an associate professor of pharmacy practice. Frequently, healthcare industry has tapped the airline industry to be able to serve as a model for safety. For the next 40 minutes, I want to discuss a drug safety issue, amiodarone-induced pulmonary toxicity. Now, that's a mouthful, so I'm going to limit it to pulmonary toxicity. But amiodarone in some ways is perhaps our industry's Tecate Airport. I mean that in the sense that amiodarone is an effective antiarrhythmic, and flying into the Tecate Airport will get you to Tegucigalpa, but it's not without peril. As a roadmap to our discussion for the next little bit this afternoon, I want to share with you some unique characteristics of amiodarone. And then specifically, I'll segue into the pulmonary toxicity associated with amiodarone. Then I want to shift gears a little bit and share with you some data that you probably aren't used to seeing, and that's data derived from negligence malpractice claims, which really piqued my interest in this topic. And then finally, finish up with some practice strategies that pharmacists could use in practice to mitigate this potential injury. So, since our time's limited, if you could hold your questions to the end, I would appreciate it. Upon completion of this learning activity, it's my aim that you would be able to list the different types of amiodarone pulmonary toxicity and describe the associated pathogenesis. That you can identify risk factors that are known to contribute to pulmonary toxicity. Be able to describe objective laboratory monitoring parameters that are recommended for monitoring for toxicity. And then finally, recite some examples of health system failures that have contributed to medication errors that cause pulmonary toxicity. And finally, explain how to incorporate some risk assessment strategies that we can use both in clinical practice as well as at the counter to mitigate such injury. Now, before we jump right into the learning objectives, I just want to share with you some of the unique regulatory perspective of amiodarone. It's one of the more colorful drugs, if you will, in FDA history. This drug was originally developed in the early 60s by a group of Belgian chemists, and it was found to have coronary dilatory effects, and so it became very useful in Europe as an anti-anginal agent. Then, in 1967, it was withdrawn from the market, curiously enough, because of side effects that related to corneal deposits and skin discoloration. Now, these are problems that we recognize as toxicity today, but it's not the ones that we commonly think of as being the ones that are most problematic. Then in 1969, a doctoral student at Oxford chronicled the antiarrhythmic effects of amiodarone, and an Argentinian physician then picked up on those and developed it further, and he very successfully used the drug in treatment of both ventricular and supraventricular arrhythmias in his patients. It was on the basis of those two that it earned approval both in Canada and the FDA, or Canada and Europe, and perhaps other places. But American electrophysiologists picked up on this data And they began getting drug from manufacturers in these two countries that really ended up becoming the first compassionate use IND that was approved by the FDA. Well, over time, more than 10,000 patients came to get the drug, and ultimately, by 1980, the drug was very popularly being used because it was considered wildly effective for atrial fibrillation. An NDA was filed with the FDA in 1983, but the FDA had a reluctance to approval. It sort of rings back to prior drugs that had been considered by the FDA and a reluctance to approve them. But the European manufacturer said, well, if you're not going to consider our drug for approval, then we're not going to give you, continue to give you free drug. Well, that put American physicians in a quandary, a potential medical crisis, because now we're going to take away a drug that's very effective. So, of course, physicians put pressure on the FDA, and in sharp contrast to any other drug of current modern day history, Amiodarone became the first drug to be approved by the FDA that did not go through a rigorous clinical trial process. Now, respectful of the drug's troublesome toxicity, the FDA limited its approval to life-threatening ventricular arrhythmias that were resistant to other therapies. But as you know, once a drug gets approval and becomes commonly available, off-label use takes off. And based on 2011 data, Amiodarone had 45% of the market share of antiarrhythmic drugs. And in fact, today it's designated by the World Health Organization as an essential drug. Now, as unique as its regulatory history is, perhaps also are some of its drug characteristics. The pharmacology of the drug, it's basically considered a Vaughan Williams class 3, but Amiodarone exhibits electrophysiologic effects in all four classes, as well as prolongs the action potential in cardiac myocytes. Pharmacokinetically, its oral administration, if not loaded as a loading dose, and generally it is loaded, given as a loading dose, if a patient were to take the drug, it would take 9 to 5 months to be able to reach steady state because it has such a slow and variable absorption rate. Similarly, then, following from that generally speaking, while some patients may experience earlier onset of antiarrhythmic effects, usually the onset of effects is not for 3 weeks, and this is using a loading dose of usually about 3 weeks, and there's quite variable in terms of the types of doses that are used. And the peak effects of antiarrhythmic effects really aren't evident until about 5 months. Similarly, if you were to withdraw the drug, and this is compounded both by the fact that amiodarone is active, as well as its primary metabolite has has activity, that when you withdraw the drug, you continue to see antiarrhythmic effects for out as long as 5 months. Half-life wise, the drug has a biphasic, but in fact it's been described as having multi-compartment pharmacokinetics. But its initial half-life, elimination half-life, is out as long as 10 days, which is far different from any other drug that we generally will deal with in practice. But its terminal elimination half-life can be as much as more than 3 months. And then in the elderly, then it's even longer than that. And of course, you compound the fact that the metabolite itself also has a long half-life. Perhaps as a function of its, or extension of its pharmacokinetic profile, similarly, it has a unique toxicity profile. Amiodarone and its metabolite both accumulate in peripheral tissue due to their affinity for interlysosomal phospholipids. Inclusion bodies have been found in lungs, heart, liver, skin, corneal epithelium, and peripheral nerve cells, which is directly explanatory for why the toxicity is seen in these organs. Now, I've provided a number of toxicities listed here on the slide, and we're not going to go into detail because we're here really to talk about pulmonary toxicity, but I provide this for the purpose to show that such a unique portfolio of adverse effects with the incidence data and the types of monitoring and the degree of monitoring, both at baseline and at follow-up, that's necessary such that we have to be vigilant as we use this drug, because the adverse effects at onset, some are days, but oftentimes it's months and even years before adverse effects onset. And so it's necessary that we follow this drug long term. Now, the most dreaded toxicity is pulmonary toxicity. I've listed the incidents here for the other adverse effects, but we're going to save our discussion for pulmonary incidents in a couple of slides. The incidence rate's a little hard to put your finger on, though, because pulmonary toxicity is perhaps the most severe and can potentially be fatal. And so oftentimes it's reported as the toxicity, which certainly would be a lower incidence rate. Whereas other studies will list rates of general pulmonary toxicity and really lump sort of all comers together, if you will, in that category. You say, well, what do you mean by all comers? Well, there are 7 different types of pulmonary toxicity that have been described in the literature. But and generally, the interstitial pneumonitis is the most common, and the acute respiratory distress syndrome, or ARDS, is the most severe and potentially fatal. ARDS is associated with fibrosis, and so the easy way to think about this is think about it across a continuum. And when we discuss the mechanism of toxicity on the next slide, it will become more evident. But it's as a result of an inflammatory process, and the longer the inflammatory process, the greater the potential to develop fibrosis. So interstitial pneumonitis is considered to be more of an acute reaction. And in patients who experience this adverse event, you take away the drug, generally they recover. However, and then the second most is the most severe, and that's the pulmonary fibrosis. ARDS is also associated with thoracic surgery and pulmonary angiography. And then finally, the last one I'll point out is the organizing pneumonia. About 25% of the toxicities that are associated with amiodarone are described in this category. The rest of them really are rare and individual case reports. Now, I mentioned the toxicity, and I apologize for the smallness, especially on this screen of the slide, but there are direct mechanisms and indirect mechanisms that are associated with the mechanism of toxicity. The direct mechanisms through a cytotoxic effect, there are an oxidant injury. This oftentimes the surgery, the risk of surgery that I mentioned in the angiography, often associated with high concentration of oxygen, which creates interactive metabolite, or what's the word I'm looking for?
Like an oxidative process?
Yes.
Yeah.
But the more common is through its inhibition of the lysosomal phospholipase. Amiodarone is an amphiphilic molecule. It has a lipophilic ring structure, and then it also has a hydrophilic side chain. Amphis coming from both, and philia meaning love, or love of both. And so this creates a phospholipid storage disorder in the lungs where the drug tends to concentrate due to a high affinity. Now, the amiodarone or the metabolite phospholipid complexes interfere with the normal endogenous handling of phospholipids, which ultimately leads to direct injury, either through apoptosis or through cellular necrosis, leading to an inflammatory process that I described before, and ultimately, if this process lasts long enough, creates a chronic inflammatory state causing fibrosis. Now let's get back to discussion of the incidence. Meta-analyses have provided some estimates of pulmonary toxicity, but generally speaking, participants in clinical trials usually are younger, but for the fact that they have atrial fibrillation, usually are fairly clean from a health perspective with fewer comorbidities. And so the incidence that we've seen in meta-analyses tends to be relatively low, or on the low end of what we see reported as normal. There are some case series, but those case series tend to be small. And for those studies that have been reported, they're usually limited to single centers. So given these limitations, I wanted to present to you a study that I found recently that was published that was a large population-based incidence that looked at pulmonary toxicity. Not only the incidence of, but also identifying risk factors for. Now, the study design is a retrospective cohort. This was conducted in Canada, in the province of Quebec. They used administrative databases that included hospital discharge data, so the ICD-9 codes that would be identified therein, prescription claim data because of the nature of distribution of drugs in Canada, and then also survival data. Perhaps you could think of this as vital statistics so that we could get death data from patients who are taking the drugs. The inclusion criteria are quite simple, greater than the age of 65, and that wasn't a function because atrial fibrillation is greater in the elderly. It's simply that the prescription claims databases only provided data for patients over the age of 65. So hence the limitation there. The other thing was that patients had to have atrial fibrillation that was both a primary or a secondary indication and non-transient, and to the exclusion, not as a complication or not onset within 30 days of cardiac surgery. Now, they also excluded valvular disease and surgery because I indicated that those are independent risk factors for pulmonary toxicity. They excluded patients in long-term care facilities. The article didn't explain why, and so I don't really have an understanding. Perhaps it related to the database and whether those residents' data is reported elsewhere. So I don't have an explanation for you there. The data that was collected, both related to exposure status as well as disease status. So for amiodarone, they collected milligram strength, day supply, duration of therapy, and then they used mathematical calculations based on the dosing to determine what the day supply was and whether they would stratify that as a low dose or high dose. Now, this is a little bit different from most other studies in that high dose of amiodarone is usually considered greater than 400, but they defined it as 200. And then, of course, a risk factor, as we'll talk about for amiodarone, is not only the dose itself per day, but also the cumulative dose or the cumulative exposure, so the duration of time. Disease state, the primary concern was the development of pulmonary toxicity and death related thereto. Other data that was collected included demographic data such as age and gender. They also collected comorbidities, and they collected information on the use of atrial fibrillation medications other than amiodarone, and also specifically CYP3A4 inhibitors because amiodarone is principally metabolized by the 3A4 isoenzyme. Statistical analysis, they provided descriptive statistics for group baseline characteristics. They also then, the data was censored either based on the first primary diagnosis of pulmonary toxicity, if at the time that amiodarone was discontinued, or at the end of the follow-up study, or death. And this was about a 10-year study. So whichever of those came first is when the data was censored. The crude incidence of pulmonary toxicity was then calculated, both for users and non-users, and they also calculated a crude incidence of mortality in patients who were on amiodarone who developed pulmonary toxicity. Now, they did this for the overall population, and because there were statistically significant differences in age between the users and non-users, with the users actually being younger, they age standardized so that then they can compare apples to apples across groups and then stratify by gender, dose, and other risk factors. Now, they used a Cox proportional hazards model, which is a survival model. And the value of this is to be able to determine an association between the survival time of patients and one or more of the predictor variables. And namely, in this case, we're concerned about when the onset of toxicity occurred and how that related to amiodarone use. Now, you might be more familiar with Kaplan-Meier curves, but the thing with Kaplan-Meier curves is that they are only good for univariate analysis, and they're only good for categorical data. And so in this regard, they used a regression model to be able to identify the predictors of pulmonary toxicity, and also keep in mind that the Cox proportional hazards model can use not only categorical data, but also continuous data. So things like age and dose and duration of therapy could be factored in. Then from that, then they calculated a proportional hazards or estimated a hazard ratio and reported the confidence intervals. They included sensitivity analysis. Interaction between dose gender and dose age factored this into the model. And they also considered prescriptions that were filled within 30 days, but the index data that they collected was based on 7-day prescription fill data. So they thought they would broaden this out to a 30-day fill to see if there was any difference. And as it turned out, the sensitivity analysis didn't yield anything any differently. Results-wise, the end of the study, there were more than 57,000 atrial fibrillation patients. So this is a real-world atrial fibrillation population, of whom there were about 6,400 amiodarone users. The crude rate of pulmonary toxicity in users of amiodarone was pretty much roughly 3 times the rate of non-users. Now, if we were to compare the crude rate of pulmonary toxicity to that reported in the literature, the widest that I could find was as low as 0.1 and as high as 50%. Well, as we discussed before, it really kind of depends on how you define pulmonary toxicity as to the rate that you're going to get. In this study, they defined it relatively broadly, picking up as many factors as would be categorized as amiodarone pulmonary toxicity using the ICD-9 and 10 codes. The more common population-based report, though, is between 1 and 15%. So in this study, so those are smaller, generally smaller clinical trials, but also some case series. Here in this large population-based, the incidence was on the lower end of that scale. It was still roughly 2 times that, though, that was reported in meta-analysis that ranged anywhere from 1.5% to 2%. Mortality data, greater than 75%. Now, how does that compare to mortality data reported in other studies? It's been reported lower at 21 to 33%. There was no explanation given for what they thought might be the difference in this regard. Looking at the risk factors, I've included here only the ones that were found to be statistically significant. We find, of course, the dose of amiodarone. Now, what's curious, though, is that you look at both less than 200 milligram and more than 200 milligram, they were both found to be statistically significant. So, in other words, roughly when you look at this on average, amiodarone users were roughly 50% at higher risk of developing pulmonary toxicity than were those patients who were not on amiodarone. Now, we know, though, that based on the fact that the toxicity is a continuum from an acute process up to a chronic process, so doses of higher doses may actually contribute to one type of toxicity, where the lower doses could still be associated with an interstitial pneumonitis. So this is not a particularly revelation, if you will, and it's not really a contradiction. It's just that we have, in fact, seen pulmonary toxicity reported at varying doses. Gender, males had a higher risk of pulmonary toxicity, but then there were more males in the study, significantly more males. Idiopathic pulmonary fibrosis has a higher incidence rate, and that men have 50 to 80% higher incidence of idiopathic pulmonary fibrosis than do women. And so that could factor into some of the baseline noise that may have elevated the risk for males. Age, other studies have reported anywhere from 50 to 60 years of age and greater are at higher risk. In their model, the hazard ratio of 1.01, so really essentially, I mean, it was statistically significant, but this is per year of age. COPD, underlying pulmonary risk factors, have been significantly associated with development of pulmonary toxicity. Chronic kidney disease was kind of a new finding, and it's kind of a curious finding as well, because when you consider that amiodarone is metabolized and not eliminated via the kidneys, we're not really clear as to what might be the genesis of this. However, there are some studies that show that patients with diminished renal function have also diminished CYP3A4 metabolic activity. So it could be that that's the cause, but it really requires some additional search to find that out. A protective effect was concurrent use of AFib rate control drugs. In other words, the rationale here is the thought if you're able to control the AFib with rate control drugs, then either your use of amiodarone is going to be lower or for a shorter period of time. Therefore, your risk of pulmonary toxicity is going to be considerably less. Their conclusions, the authors didn't overstate their conclusions. Basically, as I've shared with you, that the pulmonary toxicity was found to be in the lower range of that previously reported, and that the patients that they found, irrespective of dose, were roughly 50% higher at risk for pulmonary toxicity than non-users, and that hopefully clinicians could use their data to then further implement strategies to mitigate its development. My thoughts on the study. I like the fact that it describes toxicity in a real-world atrial fibrillation population, not just a clinical study population, but a real-world population, and in large numbers, numbers that we have not yet had seen previous. Large patient population improvement over the small samples, really in addressing that same. Now, the study was restricted to elderly patients. The fact that atrial fibrillation occurs more frequently in the elderly may actually limit any effect that this limitation might have. The baseline characteristics between users and non-users were quite significantly different, but given that they used a regression model, then it really should have ferreted out those differences, and so that probably is not really a factor. As I said, toxicity was defined by inclusive ICD-9 codes, so that may falsely elevate the rate of pulmonary toxicity that was identified. And also I described the idiopathic pulmonary fibrosis being higher in males. The fact that it's a Canadian study, I don't think from a drug perspective had any effect, because as we know in Lexicon, for example, it will provide both U.S. labeling as well as Canadian labeling, and I looked to see if there was any differences in the way that amiodarone is approved in Canada, and I couldn't find any, so there really probably is not any effect here. Shifting gears, which is really the genesis of my interest in this topic to begin with. Over the past several years, I've had a series of amiodarone cases reported to me in my consulting practice, resulting in malpractice negligence claims. And as I've done with several other drugs, methadone, duragesic patch greater than 50 micrograms, methotrexate, I have taken these cases when I get these series and then look at them to see if I can identify trends. Not from the standpoint that I'm trying to contribute back to the literature to say, here's a new finding that you haven't considered before, because certainly the numbers that I have are very small. So these will be very small case series. But it's really that taking these cases and looking at it from a malpractice standpoint to say, all right, based on what we know about the drug, how can we apply that to our population here? So I did a retrospective analysis of the malpractice claims, of which there were 6, the most recent being a year ago. These claims were independently evaluated by a physician and a pharmacist reviewer. I was a pharmacist reviewer. The data collected really mirrored what we talked about in the Canadian study I just described. The only difference is I calculated the adverse drug reaction probability score based on using the Naranjo scale. And if you're not familiar with that, we can answer that maybe in the Q&A session. And we defined preventable claim as an injury that was preceded by a pattern of inappropriate behavior that could have been predicted or detected and controlled or avoided. So we're not going to spend a lot of time on the data because this is not really contributing back to the literature. These are things really we already know. But looking at the demographics, all of the patients were elderly except for 2. We had one is 57 and one is 63. Gender-wise, this is sort of the same distribution that we saw in the Canadian study we've talked about, where males were higher than females. The arrhythmia being treated, this is consistent with the way that the drug is used, because we don't see a great deal of use for ventricular arrhythmias. It's really more for atrial arrhythmias, AFib or supraventricular tachyarrhythmias. And then there were also some risk factors underlying for pulmonary toxicity of smoking and COPD. When we look at dosing, the two things that we really found is that first, in all cases, the dose was greater than 400 milligrams per day, and in some cases up to 1,200 milligrams a day. Now, this related to the duration of therapy so that we get this cumulative dose. So this is really a function of these two columns. But we see that all but two of them were in the maintenance phase. So they had been on the drug for some chronic period of time, as you can see measured in months. But there were still two that were in the loading dose phase. As we look at the monitoring was pretty atrocious. As you can see, the monitoring adherence, and these are just really at any point in time prior to the onset of pulmonary toxicity, or toxicity that weren't all pulmonary, was there monitoring. So was it at baseline or was it ongoing in any way? And certainly there was cardiac monitoring in the form of an ECG, but from a pulmonary standpoint, 1 out of 6 patients were monitored, hepatic the same number, and thyroid only slightly better, for an overall adherence rate to monitoring of about 22%. When we look at the outcomes that occurred, and of course keep in mind these are all malpractice claims claiming injury, so we know that there's some toxicity that has occurred. In all cases, there was pulmonary toxicity except for one patient, and this one patient claimed a peripheral neuropathy. So in all these cases, it was pulmonary toxicity, and it's really the two that we have been referring to, the most common, idiopathic pneumonitis or interstitial pneumonitis, or the others were fibrosis. When you look at the Naranjo scale, which identifies probable, possible, or unlikely, or definitively no, if the score is less than 0, all of them were at the high end of the Naranjo scale, identified as being probable in terms of the relationship of the toxicity back to amiodarone. And in 3 of the 5 cases of pulmonary toxicity, the patients died. So if we take a look across all of that set of data and apply then that to the standard of care, we find that there was improper dosing was considered in 5 of the 6 cases. There was improper monitoring in 5 of the 6 cases. And that had proper dosing or monitoring been done, and this is an oversimplification without getting too much into the detail of the data, that had this type of monitoring been done and interventions applied, that more likely than not, changes in therapy would have been made, and the probability that the patient would have suffered an adverse event would have been significantly less. Now, I've included failure to counsel because as pharmacists, that's what we do, or at least in part of what we do. Now, as we know as academicians, that teaching doesn't equal learning. So just because we would have taught them doesn't mean that a problem would have been avoided, but at the same time, the patient would not have been in a position to change their dose or to be able to subject themselves and conduct the proper monitoring that was required. So clearly, these were preventable events. These were preventable claims, as I defined preventable claim on a prior slide. Really escalating this concept of adherence to proper monitoring guidelines, there was a retrospective cohort study that was done in 10 HMOs that found that only half of more than 1,000 patients who were receiving amiodarone received proper monitoring, received the recommended monitoring according to published guidelines, which have been most recently updated in 2015. Evidence also has shown that baseline monitoring is marginally better than ongoing monitoring, and as we talked about, vigilance is necessary since these adverse events really occur over months to years. So one suggested approach has been to develop an amiodarone monitoring service. So a review of the literature identified 5 different such monitoring programs. Interestingly, all of these are pharmacist-led. Now, in most cases, it's multidisciplinary. In one case, it's really a centralized pharmacy function. But you can see we have a university setting, We have two Kaiser Permanente, so a managed healthcare setting, have a VA medical center, and then this one was an individual cardiology clinic, but it was affiliated with the university, so you really would think of it as a university setting as well. These programs were designed as pharmacist-led, again, multidisciplinary. The settings were in outpatient clinics primarily. The goals were to improve laboratory monitoring and to improve monitoring for adverse drug events. And the interventions included anything from protocols to algorithms to electronic tracking of data to face-to-face patient interactions. And then pharmacists, importantly, well, from our perspective, pharmacists were importantly involved in primary roles. So again, these were pharmacist-led clinics. It's not that the pharmacist involvement was tangential. They were a central role in the performance of these services. Now, while there were significant variations in service design and outcome that really didn't allow an apples-to-apples comparison of really any of these, the bottom line is that when you look at the pulmonary monitoring and focusing on pulmonary monitoring, in each of these studies, all of them were statistically significant, except for one, which didn't report a p-value. But if we simply look at these rote numbers, which one would you pick if you wanted to be monitored either by usual care or pursuant to a monitoring service? So this is something that pharmacists can do and are doing. This is a sample protocol. This is the protocol from the cardiology clinic-based service where they're doing the initial visit, so baseline, and then 1, 3, and 6 month follow-up, and it's all defined. Now, if you're in a clinic practice setting, this is what you do. This is what clinical pharmacists do, or this is what clinicians do. But what about those patients who don't interact with a clinical pharmacist? So again, we're looking at it from our perspective. What about those who you simply encounter at the prescription counter? What about them? What is it that we can do that will enhance the provision of care to them? Is all of this necessary in order to be able to affect a change? Well, if you go back, I've given you a handout here. If you go back about 5 slides to the dosing data that I told you from the malpractice claims that I reported, and as you'll recall, all of them were greater than 400 milligrams, and many of them 8 to 1200 milligrams. Now, I want you to forget what you may have thought about it and listen to this. What if I told you that that was not intended dosing? That's not what they expected the patient to get. What happened in all of those cases were some combination of, I'll give you a couple examples. Doctor writes a prescription, take 2 tablets, these were 200 milligram tablets, so 400 milligrams 3 times a day for 3 weeks, and then take 1 tablet daily. And they put 5 refills on it. Their intention was for the patient to take 3 weeks of loading dose and thereafter take once daily dose of 200 milligrams. But what the patient ended up in that scenario doing is continuing to repeat every month 3 weeks at a high dose, 1 week at a low dose, 3 weeks at a high dose, 1 week at a low dose. And in most of those cases, it didn't take very long. It was a matter of months, but still to develop toxicity. Another common example was not that it was written that way, but take 2 tablets 3 times a day with 5 refills. And so there was no step down. They really intended to give them a loading dose, but I'm sure they didn't intend to give them 5 refills. Now, if you were the pharmacist doing a prospective drug utilization review at the prescription counter, would you not expect either cognitively just what you have learned in pharmacy school about amiodarone and that this is not a chronic dose, or would you not expect that the clinical algorithms driven by the dispensing system to pick up on that dose and say this is an excessive dose? And at that point, the pharmacist can intervene, call the physician, take a prescription over the phone that said, or just call and tell them, look, I'm going to change this prescription. I'm going to make these 2 separate prescriptions. I'm going to give them 1 for the loading dose, and then I'll give them 1 for continuing therapy. What dose is it you want them to continue on? And so we don't have to have something as extraordinary, if you will, of a monitoring service But we can simply do this at the prescription counter. And I think we need to teach our students that that's the case. That certainly would have been the case in all 6 of the claims that I presented to you. And as I indicated, had the dosing been managed, the probability of an adverse event would have been significantly less. So in summary, pulmonary toxicity is infrequent, but certainly a severe adverse event with amiodarone. Pulmonary toxicity with chronic amiodarone can be prevented. Risk factors, and these risk factors I have gleaned now from a variety of sources, that most commonly include doses that are greater than 400 milligrams a day, chronic use, and even if you conservatively consider it 2 years, but simply chronic use, period. And if you go back to the prescription counter and each month that a patient comes in, how many times do you think you're going to see amiodarone, quite frankly, relative to opiates or lisinopril or NSAIDs or something else? To make it a point to ask that patient, are you having any difficulty breathing, any dyspnea, anything that would continue to highlight for them to have a high index of suspicion that if you develop pulmonary symptoms, you need to bring this to the attention of your physician. And then certainly any underlying pulmonary disease, and certainly for the elderly patients, these are risk factors. Baseline monitoring, and as I just mentioned, the high index of suspicion are necessary elements to prevent toxicity. Failure to identify these risk factors and do proper monitoring have been published in the literature. I've given you evidence in actual practice where caregivers' lives and certainly patients' lives are being significantly affected, resulting in these negligence claims. And there are risk assessment programs that can be done, anything ranging from a simple, effective prospective DUE or DUR up to an amiodarone monitoring service. So, what have we learned? Tuscaloosa International Airport has been the scene of no less than 160 aviation fatalities since 1989, most of them involving commercial jets. The biggest crash to date was this one, 2008, when Taka Airlines landed halfway down the runway and skidded off the runway at the end on a rainy day. Now, as you can see, fortunately, this one didn't erupt into flames or combust, but there was still significant injury on this flight. Now, if you consider the average sized commercial jetliner with typical fuel, typical payload, the average landing speed is 120 to 160 knots, so about 150 to 200 miles an hour. If we consider the slowest speed, and you figure that at that land speed of 150 miles an hour, convert that to feet per second, and then factor in that 500-foot landing space, the pilot has 2.25 seconds at the most to land that jumbo jetliner. You'd think it's time to build a new airport. But then we're not talking about airlines, we're talking about amiodarone. As demonstrated, current amiodarone monitoring practices, put the best way, are suboptimal, but quite frankly, they're atrocious. And it's potentially due to a fractured healthcare system, general practice versus specialty practice, whatever it is. But if you want to use airline analogy to discuss this, Tuscaloosa has a short runway, amiodarone has a long half-life. Tuscaloosa has a rugged and unique terrain, both on approach as well as reaching the landing strip. Amiodarone has a unique and rugged adverse event profile. Tuscaloosa Airport is unlike any other airport in the world, so is amiodarone. We mentioned many of the unique characteristics that it has. So irrespective of what we've seen, whatever you believe of the data, but the p-values, simple p-values speak to it, that if we as pharmacists simply step up and do the things that we recognize, the things that we know, then we can affect a significant difference in making a dent in the toxicity that's occurring, because we can't allow amiodarone to become Taka Airlines. Thank you for your attention, and I'll entertain any questions. And these are my references.
It's a great presentation, and as somebody who has stood behind a pharmacy counter for well over 30 years. Seen a lot of amiodarone toxicity, and a lot of times we identify them when they walk in the pharmacy because of, we call them the blue men or the blue women or something like that, because they're you see the dermatologic side effects before you can realize that they have the pulmonary. So as pharmacists, what of course, reimbursement's always at the top of the list. How do if these pharmacist-led services were obviously effective? So how do you propose that we present that to become something that we can offer our patients, but also make it viable for our profession?
Well, pharmacists have put themselves in this catch-22 where for years we've given away everything we know. And perhaps we do so because we're not recognized as providers. Hopefully things that have happened in Little Rock in the legislature are beginning to affect that, and we're seeing the movement in a big way in Washington. So that has nothing to do with amiodarone, though. But I think from a system standpoint, from a healthcare system standpoint, especially when you're considering capitated payment in some form of managed care, if they're Medicaid patients for whom are, like in Arkansas, or in patient-centered medical homes, then if you can decrease your health expenditures trying to treat adverse drug events, then you're saving money for your practice. So at a minimum, while we may not be able to bill for the service, that if a pharmacist is part of that health system, then the pharmacist can show their weight in gold, maybe not by billing for new services, but by saving money due to expenditures in treating adverse events. But for the average run-of-the-mill pharmacist, and I don't know how many clinical pharmacists there are relative to dispensing pharmacists, but it has to be a small percentage, that the lion's share of pharmacists in the U.S. are behind the counter. Or if they're not behind the counter, they're in the central pharmacy in a hospital. Those are the largest number of places where pharmacists exist in practice. Prospective drug utilization review is not expected to be a reimbursable service. It's expected to be a minimum part of what you do. Over 90 saw to that. Now that doesn't apply to hospital practice, but hospital practices has been going on long for many years, and in fact, in some ways may have had an impact on over 90 passing to be done in the community store setting. So from that perspective, I think that for the lion's share, that for the claims that I presented to you, that we can affect the change there without having to spend an inordinate amount of time. You don't have to do an hour-long MTM session. It's simply part of what you're doing at the dispensing counter. I don't know if that answers your question, Dr.
Yeah, it does a very good job.
I'd like to build off that question, being sort of a communication person myself. What specific things, since we don't want to spend an hour-long counseling, what specific things in the short period of time that the pharmacist behind the counter has with the patient, what specific questions or pieces of information would you recommend be communicated so that it doesn't get to this atrocious monitoring place afterwards? Some specifics.
Okay, and recognizing the discussion today really was focused on pulmonary toxicity, but I'm going to broaden the answer in that thyroid function, liver function, pulmonary function, all of those require baseline monitoring, but then ongoing monitoring, but they vary across toxicity as to when you get that monitoring. For example, pulmonary monitoring, there's some debate as to whether because the interaction of radiation might actually stimulate an inflammatory process. And so they're suggesting that maybe you don't want to be doing routine chest x-rays, or the pulmonary function tests, are they really necessary when there aren't any evident toxicity? What you really need is have some baseline for comparison purposes. But from the prescription counter and talking to the patient, then something as simple as I mentioned before, simply asking about respiratory symptoms. Just asking, inquiring how they're doing, whether it's thyroid, whether it's pulmonary. So, or you could have a more specific is, does your physician have you coming in for regular drug monitoring? And if not, let me give you a list of the recommended monitoring that's due, and you could create a one-page handout that becomes part of your counseling if it's not already incorporated in the counseling material that's given to you. So that's one, is asking about their laboratory monitoring. Is your physician doing this? Two is inquiring about specific symptoms, particularly pulmonary toxicity, because it's an easy one to monitor. Plus, anytime that you see them coming in for respiratory meds, whether it's cough medicine or whatever, then that might be an opportunity for you to really extend your prospective DUR. And then just asking the patient to make sure that they know how they're taking the drug. Because if you have a patient, especially on patients who are newly started, that if they're starting a loading dose, to make sure that they understand this is intended for a limited period of time. You're not going to be taking this forever. So make sure that you don't get caught up in that. So these are just really simple things that the patient, as long as they're a reasonably good historian, would be able to directly respond to. And you can have that conversation with them without getting into detailed treatment algorithms.
Right.
Does that answer your question?
It certainly does. And it caused another question to come to my mind, which may be out of the scope of your study here, but considering that counseling and monitoring is so important, did you run across in any of your research the issue of adherence rates with this particular medicine? Are they how that works? Because with many of your, for instance, hypertensive medications, they work, but the adherence rates are horrible. So did you run across anything like that in any of your studies or research?
So you're specifically talking about, so I think all of this is being picked up, and we're in a small room here, so I think it's being picked up on video. So I don't need to repeat the question, but so you're specifically talking about the patient's adherence to taking the drug regularly.
Yeah.
The answer to that is no. I didn't find anything that came up in terms of a risk factor.
Okay.
Certainly, the expectation would be that they're not over adherent, that they're under adherent, in which case their atrial fibrillation would be uncontrolled. But I didn't run into anything as it relates to medication adherence. Certainly, there was adherence data regarding failure to monitor, but that's more adherence of the healthcare provider, not the healthcare or the adherence of the patient.
Well, then one other thing, and again, I know this is sort of maybe beyond the scope of what you said here. You did a great job of comparing males and females and why males have a worse side effect profile. Was there anything about ethnicities? Because we know that, for instance, Black patients respond very differently to heart medications, high blood pressure medications, these types of medications. Was there any research done on ethnicity and the impact of these toxicities on, for instance, the Black population or the Asian population, which would be very high in Canada?
Okay. I have not seen specifically as it relates to risk factor for toxicity, really of any kind per se, or factoring in as a risk factor that you would monitor for. I think it's reasonable, though, that you could anticipate that since amiodarone is metabolized by the cytochrome P450 system, and specifically 3A4, which is a very predominant isoenzyme, but it's also one that doesn't have a lot of polymorphisms. So, unlike the 2D class of isoenzymes, there are a great number of polymorphisms that are associated with that class of enzymes. But 3A4, I'm not particularly aware of. So there may be some differences in genomic handling as it relates to different populations, and specifically Asian population comes to mind, but nothing that I'm familiar with as it relates to amiodarone metabolism.
Okay, thank you.
Thank you.
Was there anything, and I know that the number of folks in the study were relatively small that were on amiodarone, but it was interesting to me that the hazard ratio was actually higher with the less than 200 milligram a day dose than the greater than 200 milligram a day dose. It may not have been statistically significant, but that kind of popped out at me as we were going through that.
Well, there are some studies to report that the incidence of toxicity is greatest within the first 6 to 12 months, but that if you get a patient who is stabilized on the lower doses, that once they get beyond that period of time, that while cumulative dose is a factor, that if they're on the lower dose, then it takes longer, and so therefore you may actually see a depressed rate of toxicity. And so I don't know what might be the difference that would explain between the two. There were certainly data to show between users and non-users that irrespective of dose, which is borne out in other studies, that both, really at all dosage levels, we have seen pulmonary toxicity. It's just what type of toxicity. And in this study, they didn't really differentiate between pneumonitis or fibrotic disease. I don't know if I answered your question.
No, yeah. I just the indication for amiodarone is for folks that have been refractive to other antiarrhythmic medications. So if we get, as pharmacists, if we are the ones counseling and possibly intervening in their wellness, identifying not only the pulmonary toxicity, but some of the other toxicities that are associated with the drug. I haven't stayed up with the, what is this, a class 3 antiarrhythmic, I think. Stayed up with those. Is there alternatives for treatment that we as pharmacists could recommend to their prescribers? Or
well, this is one of those things where it's really kind of a hit or miss in terms of your choice. But I'm going to go back and change your question, because at the genesis of your question, or at the outset of your question, you said that this is a drug reserved for refractory patients. That's what it's indicated for in ventricular arrhythmias, but amiodarone is probably considered first line for AFib. If you're going for rhythm control, amiodarone is your first choice, because it is so highly effective. And probably because it has some vagolytic properties, it has all 4 electrophysiologic properties of the class 4 von Williams. It has an effect on inhibiting the thyroid hormone. All of these probably go together to speak to its efficacy as an antiarrhythmic. So it's really, and if you look at the market share data, amiodarone has almost half the market share of the antiarrhythmic. So I think that speaks to the fact that it's very effective, but it's very toxic.
Very toxic. Okay.
So gentlemen, any other questions?
You've done a great job of covering this topic.
Yep, very good, very good. Very thorough.
Well, I appreciate your time here today.
Thank you.
Thank you.